Morning. Yes, I'm Georgie and I am a sleep researcher based at the University of Birmingham. And I'm here this morning to kind of set a little bit of context for you as we come to think about some findings about sleep in TSC specifically. So I'm going to start just by thinking a little bit about what sleep is, why it's important, and why it might be sort of particularly important in syndromes like tuberous sclerosis complex. So sleep, I think a lot of people can kind of assume that sleep is sort of this passive state, but actually it's really, really important, and the brain and the body are doing a lot during sleep. So we know that sleep, for example, is really important for cell growth and repair, for healing after surgery, for lots of kind of aspects of learning. So memory consolidation, for example, happens during sleep. And we know that when we don't sleep well, we can experience kind of negative outcomes. So we know, for example, that insomnia, which is a sleep disorder we'll come back to, is associated with anxiety and depression. We know that when we can't sleep, we can struggle to concentrate, we can find ourselves feeling quite irritable, having low mood. And it actually also impacts our kind of appetite as well. So there's some really interesting literature about how you're sort of not able to regulate your appetite and perhaps some of your other behaviours as well. So we know that people can be more impulsive if they haven't slept well, and take more kind of risk-taking behaviours as well. And so I think these are really important to bear in mind, particularly that if we have sort of done any work in sleep, if we're a parent, we know that actually lots of children don't sleep really sweetly like this child here. Actually, when we're most kind of interested in sleep is when it sort of goes wrong, and when we have kind of problems with sleep. And actually sleep problems are really, really common. So sleep problems occur in between 6 and 43% of typically developing children. And these estimates are taken from lots of different papers, and we'll sort of come back to why they might be so broad in a moment. But for some sleep disorders, they are particularly kind of high. But I would argue that actually sleep is even more important in individuals with intellectual disability or rare syndromes like TSC, because we know that some of these aspects of well-being, of wake, of learning are all already perhaps different in syndromes or different in people with intellectual disability. So if we already have a syndrome where we have a profile of overactivity and impulsivity, if there's some kind of difficulties with sleep, it might be more difficult for individuals to regulate behaviour. We know obviously that learning can be delayed in people with intellectual disability. So it's really important to look at how sleep might be underpinning some of these factors. But I think it's also really important to acknowledge that sleep problems are not only potentially more impactful in individuals with intellectual disability, but they are also more prevalent. So this is the prevalence estimate for a range of papers. So this is taken from a meta-analysis by Tietze et al. So you'll notice again, the estimates are very broad, but they're also high, and they are higher than in typical development. And so this is something that I've sort of spent a lot of time thinking about and wondering why people with intellectual disability might be more vulnerable to sleep problems. Now, this is a diagram that sort of sums it up, and this is something that we put together for Cerebra a number of years ago as part of the sleep guide that we wrote for them. And if you're kind of interested, you can scan this QR code, and I will show this to you again at the end to access the full guide where we go into a lot more detail about all of these. But this is just to show you that there are kind of lots of things going on that might lead to a sleep problem for a person with intellectual disability. And together we're going to look at some of those today, and particularly how they relate to TSC. But returning to those kind of broad, very, very sort of wide prevalence estimates that you can see here, I think there's a couple of reasons why they are so broad that are going to be themes that kind of come up throughout the rest of the day. So the first thing to say is I think that lots of these studies, what they're doing is kind of pooling together quite different things. So what they're doing is asking about sleep as a kind of unitary concept, when actually we know that sleep disorders can be very, very different. So I've listed on here kind of some of the broad categories that we have for sleep disorder. It's worth noting that we will have specific sleep disorders within these as well, so kind of subcategories. And all of these likely have kind of different causes and different treatment approaches that we would take, but they can have overlapping symptoms, and so this can lead to kind of everything getting clumped together in these broad prevalence estimates. So that's one thing. I think we're looking at lots of different things at the same time. But the other thing is that we don't necessarily have the best methodology necessarily, or we're using lots of different methodologies, again, to assess potentially different things and combining those together. So some studies will use broad parent report measures, where we ask, does your child have a sleep problem, yes or no? Quite easy to conduct, but not necessarily very specific. Might be a lot easier for someone to score as having a sleep disorder there, versus doing a kind of full polysomnography assessment with lots of wires and an overnight stay in hospital that might not be suitable for some children with intellectual disability or adults with intellectual disability. And I know Stacey's going to come back to some of those kind of methodological issues, but I think it's just worth noting here that that might be why we have these kind of broad estimates. But so for today, I'm mainly going to focus on insomnia. This is what I've spent most of my time kind of researching. I think this is where we have a kind of a good basis in psychology to understand it and to think about some specific TSC factors. Kathy will be picking up some of the other disorders here. So if you're interested in those, don't worry, we are going to get to those today. But thinking about insomnia, so when we're thinking about insomnia, really this is what we think of when we first think of a sleep problem probably. So it's an issue with being able to fall asleep, so difficulty settling. It could be an issue with waking overnight and being awake for a long period of time, or waking very, very regularly, or waking very early in the morning and not being able to get back to sleep. And obviously this can be difficult for lots of different reasons. And so the estimates that we have in the typically developing literature suggest that insomnia is quite common, particularly in childhood. So 1 in 4 typically developing children will experience these problems at some point. And this 45% is for an intellectual disability sample taken from my recent meta-analysis. And what these really suggest is obviously it's common in both groups, but it's more common in intellectual disability. But I think the other thing to note is that typically in typical childhood, we see insomnia, or we see some of these symptoms, but they are quite sort of transient. So they might be associated with starting school, perhaps changing a bedroom, moving in with a sibling, or moving out from sharing a bedroom. And they tend not to kind of persist, whereas for people with intellectual disability, these problems can really persist on into adulthood as well. So as I said, there are lots of different reasons for that, and we're going to sort of pick out some of those that are particularly relevant to TSC, I hope, today. But just the first one that I kind of wanted to focus on, this is the idea that there is a kind of a learned association between the child's waking behaviours and parent response. And this is what we will call kind of the behavioural understanding of insomnia. Now, I think it's worth saying this is how we understand insomnia in typical development, and I think it's very useful in groups like TSC, but with some kind of caveats that we'll get onto. So just to explain this model, if you're not familiar, it's very similar to the model that we would use to understand behaviours like self-injury or aggression. So if you're a parent, you might have heard it applied in that context for your child before. But the way that it starts is that the child wakes up, and you're going to see the child's behaviour occur on the screen in blue. And then they show some crying or challenging behaviour. That might be self-injury, it might be leaving the bedroom, it might be calling out to the parent. And in the sleep world, we tend to call this a signalling behaviour. So this is a way of signalling to the parent that they're awake. And then the parent, who's going to come up in orange, experiences this as aversive. And that could be because the behaviour itself is difficult to watch, if it's self-injury or if it's very loud crying, or it could just be aversive because it's 3 o'clock in the morning and everybody needs to be asleep. And so that parent is bound to, in that situation, act. And this act will be a form of engagement with the child. Now, I just want to say here, it's not necessarily a kind of positive engagement in that kind of sense. It's not necessarily that the parent is saying, oh, well done for being awake. It could be that the parent is actually sending the child back to bed, telling them off, or it could be that they are getting into bed with the child, giving them a cuddle and a biscuit, whatever it is. That kind of engagement can be rewarding for the child, and so the next time they wake up, they're more likely to show that signalling behaviour. And this is what we call positive reinforcement, because the behaviour is being strengthened by something being added to the situation, so the parent's response in this case. Not necessarily that it's a positive interaction, but because the behaviour is increasing, we see reinforcement here. And the behaviour, the child, if they are then kind of engaged and sent back to bed or whatever it is, the signalling behaviour stops. And this in itself is rewarding for the parent because they have found that aversive and you know, they've managed to get their child back to sleep. And so the next time their child wakes and shows these behaviours, there's an increased likelihood that the parent will show the same behaviours. And so over time, these two cycles get locked together in what we call mutual reinforcement. And in the short term, it's kind of effective for the child and the parent to get the child back to sleep quickly. But in the long term, it can mean that these kind of interactions become more and more prolonged overnight and can lead to some other kind of difficulties. So as I said, that's the model in typical development, and it has been usefully applied in individuals with intellectual disability as well. But I think it's really important to note that we do need to kind of show some syndrome level sensitivity, I think, and think about other factors that might kind of add on top of this, or perhaps be even more important than this in specific syndromes. Now we're here today to talk about TSC, obviously. So TSC, Stacey's kind of already introduced. But I just wanted to say that there is a kind of specific profile that we've seen from the literature already, limited as that may be, which we'll come on to, for TSC, which is a kind of high prevalence of insomnia and excessive daytime sleepiness. So what you can see here on this table, this is from my recent meta-analysis that we mentioned, and where you see these kind of 2 pluses, that indicates a sort of priority intervention, priority sleep disorder for intervention in that group, based on the literature that we have that I was able to kind of pull together. And we did this for not just for TSC, for 19 different genetic syndromes, and you can see all their profiles here. And I'm aware it's small, but this is really just to say, obviously not all of the rows look the same. And so that kind of, you know, for me, highlights the importance of having some kind of syndrome sensitivity in our work with individuals with intellectual disability. So looking at the data in a little bit more detail, this is a forest plot. So if you're not familiar with a forest plot, basically what it does is pull together different findings from different studies, which you can see down the left-hand side. So the name here is the name of the first author, the name of the study, and then the prevalence down the right-hand side. And then basically what happens is the kind of meta-analysis pulls together these prevalence estimates, and this diamond is the kind of pooled estimate drawn from all the studies, based on the kind of quality and the number of participants in each study as well is taken into account. So I don't want to go into kind of a lot of detail here. This is really just to say that if you look down the left-hand side, you'll note a couple of things, hopefully. So the first thing is that there aren't that many studies. So there isn't a lot of literature to date looking at TSC and the sleep kind of patterns and profile. Secondly, some of them are quite early on, so kind of early 90s, these kind of key initial findings. And obviously lots has changed in the TSC community since then. But also just to say that they are fairly kind of spread. So the pooled kind of prevalence estimates will come up now. So we can see that about 52% of individuals with TSC will experience insomnia. So not only higher than typical development, but higher than the kind of overall estimate from that meta-analysis. 46% will experience excessive daytime sleepiness. And then we had this kind of general category, which was really where studies had not particularly well defined what they were asking. So they were typically asking parents about a sleep problem. And so really that probably does reflect these kind of 2 bigger issues in TSC, but it could also reflect some of the other sleep disorders that Kathy's going to come on to, but they just sort of weren't specified. And so overall, we see in TSC, for all the different types of sleep problems, a prevalence of 45%, with again, those kind of broad prevalence estimates, and that's broad kind of confidence intervals, sorry. And that's because, again, these studies were using different methodologies. So this Brunei paper is a polysomnography paper, other papers were using questionnaires. So it's quite a kind of a mix of data there pulled together, but that's just to give you an idea. So the sleep problems are, you know, fairly prevalent in TSC from the limited data that we have. So I want to spend the rest of the talk just thinking about a couple syndrome specific, or syndrome sensitive, I should say, factors. So the first one is thinking about epilepsy and kind of seizures and medication. which could contribute. So I just want to say at this point that I am by no means an epilepsy expert, and I think Kathy's going to talk a bit more about this from the kind of medical perspective. But just to say that we do know there is kind of a complicated relationship between sleep and epilepsy. Unfortunate bedfellows, as Given and colleagues have called it. I found this diagram quite helpful, and really all it does is sort of suggest that when there is kind of the presence of epilepsy, sleep can become fragmented, because basically what happens is that the more fragmented your sleep, the more likely you are to have a seizure, and then your seizure threshold is lowered, and this cycle kind of continues. And the presence of other sleep disorders, so things like insomnia or perhaps sleep-related breathing difficulties, other things like that, can also contribute to that sleep fragmentation. And so the cycle kind of gets perpetuated. And importantly, there are some anti-seizure medications that are particularly known to have impact on different aspects of sleep. So that's this Jane and Glauser paper if you're more interested in those kind of details. But we do know that anticonvulsants do impact sleep as well. And obviously from this, we see excessive daytime sleepiness, which we saw picked up in the meta-analysis, and of course those kind of adverse effects on learning and behaviour we talked about at the beginning, and reduction in quality of life for children and caregivers. So in terms of what we can do about this, we know epilepsy is common in TSC, so we need to be aware of that. And when we're doing sleep assessments for individuals with TSC, we need to consider the relationship between the medication the child or the person is on and how that's kind of impacting their sleep as well. And then finally, I just wanted to dwell a bit more on pain and discomfort. So pain, we know, can be very difficult to assess in people with intellectual disability, particularly if they are not able to verbally kind of communicate, or they're not able to accurately label and communicate their own internal state. And so we do have a measure called the FLAC, if you're not familiar, which basically is a rating scale that we can use to assess pain in people who are unable to communicate. And what we do is look at a child or an adult and basically look at their face, their legs, their activity, their crying, and their consolability, and rate that on a score of 0 to 2, and higher scores indicate that the child is in more pain. And this has been, these scales have been validated using children who are kind of pre and post surgery. So we know that these are really reliable markers of pain in individuals who can't communicate. And so what I was interested in doing, not in TSC, but in 2 other syndromes where we see health problems and we see intellectual disability, was look at whether these markers of pain are present overnight. And if so, think about how that might contribute a little bit to poor sleep. So what we did was put video cameras in children's bedrooms overnight, and we coded about 87 hours of footage of children sleeping and waking and kind of looking at what was going on. And one of the behaviours that came out was really, really interesting, is this idea of kind of leg movements here. So the leg movements, as I said, is one of the scales of the FLAC. And to score a higher score on the FLAC, you need to be showing kind of quite jerking, restless leg movements, perhaps kicking, squirming, that kind of thing. And what we actually saw was that children with Angelman syndrome and Smith-Magenis syndrome, so again, not TSC, but syndromes where we see kind of some similar aspects, we saw that children were awake and then immediately kind of showing these leg movements. So where you see filled in boxes that are red, that indicates a significant kind of probability of those behaviours occurring at that time point. So children were showing these behaviours when they woke up. But importantly, in the Angelman syndrome group, they were also showing them before the waking. So this is in the 10 minutes prior to the time of waking. Children were already showing those kind of jerking, restless leg movements. There's a couple of ways we could understand these findings. One of which could be around restless leg syndrome, which I think Kathy's going to touch on a bit more, but that's kind of a sleep disorder in itself. But it could also be that this is an indicator of pain in children before they even wake up. So this idea that being in pain could potentially be what wakes children. And I think that's really important when we come back to our sort of behavioural model. And as I said, this is something that we use all the time, but it's really important to think about, I think, what happens before the waking. So what causes the child to wake up? Is that the sleep fragmentation from the seizures, which it could be in TSC, or is it potentially pain from an underlying health condition? And I think we need to, as clinicians and researchers, be aware of these kind of factors, so before the child wakes up. And we need to kind of consider those when we are looking at sleep, when we're assessing it, and when we're thinking about intervention. So before we try and tackle this child signalling behaviour, before we try and tackle this parent engagement, we need to be thinking about why the child is waking as well. So this is a little bit of a kind of whistle-stop tour. So hopefully I've been able to demonstrate that sleep is important for every aspect of wake, and yet sleep disorders are really common, especially in children with genetic syndromes. We don't have a lot of sleep research in TSC to date, which is why we're really excited about the eSNORE project. But what we do have suggests that there's a high prevalence of insomnia and excessive daytime sleepiness, and these are likely to be related to pain and/or seizures. And it's important to rule these out before we are kind of treating poor sleep in this group. Just a quick note before I finish on ways to help you do that if you are a clinician or a parent. So this is the QR code that I showed you earlier for the sleep guide. So if you'd like any more detail about that diagram, there's also a lot of detail about lots of different syndromes in there, including TSC, and how we might go about assessing and treating poor sleep. And the first stage of that is always to keep a sleep diary. So there is a copy included in the guide for you. I should just say, if you're a parent and you're worried about your child's sleep, this is the first step. So do keep a sleep diary of your child's sleep for about 2 weeks, and that will really help you when you go and see a kind of clinician. We also want to highlight the pain guide, so written by other colleagues of ours, again with Cerebra. This is really helpful in just understanding how we might look for pain in individuals that can't verbally communicate. So it's a QR code for that there. And then finally, just if you need to go straight to the FLAC scale, if you want to just do a quick kind of observation, watch an individual for 10 minutes and rate their face, legs, activity, crying, consolability, you can scan this QR code and it takes you straight to the Cerebra infographic for that. So yeah, all that remains to be said is just thank you so much for listening, and thank you to our partners and funders, and a particular thank you to all the children and families that we have the pleasure of working with. Thank you.
Thank you, Georgie, for that wonderful introduction. And I can't overemphasize actually how important that meta-analysis data is to start to sort of understand syndrome, sensitivity, I think was the word you used, around different types of sleep disorders. So I'm just going to share my screen, so bear with me a second. Here we go. So my name is Dr. Cathy Hill, and I'm a clinician leading a children's sleep disorder service down at Southampton Children's Hospital. And I've had the pleasure of working with the Birmingham Cerebra group on this research project. So I've been asked to talk sort of more generally about sleep disorders. As Georgie very nicely introduced, you know, it's very typical that families will present with a sleep problem, and the task obviously of the clinician is to then sort of try and unpick, well, you know, first of all, is it a problem, you know, by standard definitions, and what is the underlying sleep disorder that's causing that problem? And like any of these things, before we start, of course, we have to understand what's normal. And, you know, I guess the commonest question I get asked in clinic is, you know, is my child getting enough sleep? And that's a really tricky one to answer, actually. There's some fabulous data published back in 2015 from the National Sleep Foundation, and this little infographic gives you an overview of their data. Now, this rather simple picture was actually generated by an expert consensus group reviewing, I think, over 700 different research papers trying to link duration of sleep in children of different ages with a whole variety of physical and cognitive outcomes to try and nail, you know, how much sleep the children really need. And the blue bars that you can see in the middle is what they consider normal, but you can see actually the huge variety of normal. So, you know, within your teenager, anything between 8 and 10 hours is considered normal. And the green bars might even yet still be appropriate. So then in a teenager, you're talking about anything between 7 and 11 hours. So you can see we're talking about a very wide range of normal. And then what about other aspects of sleep? So more recently, the same expert group has come back and made some recommendations about two things, about, you know, how many night wakings are normal in children. And what I would say by here is it's important to define this, because children will very frequently have brief brain arousals that parents won't be aware of, they certainly won't be aware of. They may follow on to full wake-ups, but what they're talking about here in this particular review paper and set of recommendations are about what I'd call behavioural wakings. In other words, wake-ups when the parent is aware that the child has woken from sleep. They're either moving around or engaging in play or wanting attention. And as you can see, they actually were fairly crude sort of recommendations. So anything up to 1 wake a night is sort of normal at all ages. And actually waking up to 3 times a night is also possibly okay, or, you know, uncertain, up to the age of leaving of teenagers, so throughout childhood. So again, sort of, I think that echoes really a certain amount of lack of research and lack of certainty around what is normal. The other thing that perhaps there's more certainty about is what is considered normal in terms of how long it should take a child to fall asleep. And there's a broad consensus that anything more than 30 minutes, and that's from the time the child's been settled into bed, sorry, and that the light has been switched off. So the idea that, you know, the child should be falling asleep within 30 minutes is what is considered normal. So those are sort of very crude parameters. In order to understand any sleep disorder in a child, it's important to have some overview of what happens within normal sleep. And as I'm sure you all know, sleep is not one brain entity, it's multiple different brain entities. So the brain journeys during sleep through different, what we call sleep stages. So the first part of the night is mostly what we call stage 3 or deep sleep. And the latter part of the night is more light or stage 2 sleep and REM sleep, which are these red bars that you can see on the illustration here. So each single sleep stage orchestrates profoundly different physiology, both within the brain and throughout the body. And actually each subserves probably a slightly different function. Georgie alluded to all those really wonderful, rich activities that happen across our body and brain when we're asleep. And these are to some extent sleep stage dependent. But importantly, different sleep disorders will be more likely in different sleep stages and at certain times of the night. And if you've got an idea of the picture of how sleep progresses through the night, it helps you a little bit to understand that. And one thing to note on this illustration, I think that there's 3 take-home messages. One is that deep sleep's mostly at the beginning of the night. The other is that dream sleep or REM sleep is mostly towards the end of the night. And the third and final important point is that it's perfectly normal for children to have these brief behavioural wakings during the night. So waking at night is normal. So as I said, the challenge is that all of these sleep disorders can present in very similar ways. And I guess the commonest complaints are my child can't fall asleep, they might wake up early, or either they're waking at night or they're doing some unusual behaviours or during the night. And the skill within a sleep clinic and the skill for a sleep clinician is to ask all the right questions and do the correct and appropriate tests if necessary to decide what the underlying sleep disorder is. And we think of sleep disorders in categories, as Georgie's alluded to, and these are all defined in great detail by the International Classification of Sleep Disorders. And under each of those headings, there are multiple subcategories and different disorders. So insomnias, Georgie has alluded to, and certainly within children with chronic insomnia, the predominant understanding and model is a behavioural one, although anxiety can also be a major driver of insomnia. The other category that I'm going to talk about, and the ones in green will be the ones I will just sort of give you a brief overview of, are breathing disorders and sleep, parasomnias, sleep-related movement disorders, circadian wake disorders. I'm not going to talk about circadian rhythm disorders. These are relatively common in adolescents right across the typically developing and developmentally disordered spectrum, but I won't focus on that because of lack of time. And also the hypersomnias, which are actually fairly rare disorders, so things like narcolepsy, for example. Okay, so just let's talk first of all a little bit about parasomnias. So all that parasomnia means is an unusual behaviour in sleep. But what we typically think of, the commonest parasomnias in children are parasomnias that arise from stage 3 sleep. That's a non-REM type of sleep. If you remember from the previous slide, that's towards the early part of the night. And what's happening is that the cortex is sailing along happily in deep sleep, so part of your brain is asleep, but there's an uncoupling of the sleep state and wake behaviours. So in simple terms, parts of the brain are awake while other parts of the brain are asleep. And what that results in is sort of some very odd behaviours in sleep. So the typical non-REM parasomnias of childhood are sleep terrors, confusional arousals, and sleepwalking. So these are common things that most parents will have heard of and many, many parents will have experienced. Very often there's a family history, so very often a parent will have had sleepwalking or have had sleep terrors in their own childhood, or a sibling may do the same. And the important thing about this is it happens early in the night, typically within 45 minutes to an hour of sleep onset. Just to differentiate parasomnias from epilepsies, particularly one of the commoner epilepsies is sleep frontal lobe seizures. So the timing in the night. So parasomnia is much more likely in the first half of the child's night, whereas epilepsy can pop up at any time. And that's because we know the typical time for epilepsy to occur, the commonest sleep stage is stage 2, which as you can see occurs throughout the night. Parasomnias tend to be quite brief. Parasomnias tend to vary quite a lot in their duration, whereas epilepsy tends to be quite brief. So normally epileptic episodes of the frontal lobe seizure type particularly will normally last no more than a few minutes. Children tend to be amnesic, in other words, they can't remember parasomnia. So if a child is verbal and able to talk about what happened in the night, they certainly won't remember the parasomnias unless a parent has woken them towards the end of the event. Whereas with frontal lobe seizures, sometimes, depending on the precise location of the frontal lobe seizure, children may have some partial awareness of what's going on. Parasomnias tend to be single events. Occasionally, I do see children who have 2 sleep terror events during the night, but generally, classically, it's once, and generally it's happening within 45 minutes to an hour of sleep onset. In contrast, frontal lobe seizures may be multiple episodes during the night. But the real discriminator is actually seeing the event. So what we call semiology, what does this look like? And the point is that a frontal lobe seizure generally is highly stereotypical in how it presents. So if you can capture the start of the event and you play multiple videos, and we've got some beautiful clinical material that we show in our clinical sleep training to professionals, where it's the same child, it's different episodes, but the start of the event looks absolutely identical. So the child goes into exactly the same posture and it follows the same track, if you like, through the body for the first 10 to 15 seconds of the event. That's not always obvious if you go in to the child's bedroom after the event has started. So capturing these events on video is incredibly useful. Okay, so I'm conscious that time is going to be moving on. I think what I would do is I'm going to skip the first of the sleep-related movement disorders. This is one that's a particular interest of mine, and so I put it in partly for that reason, but I'm conscious that time is short and it is a rarer disorder. But what I'm going to do is skip on and talk about restless leg syndrome, because it was something that Georgie alluded to in the research on pain and the home video, and I think that's fascinating that the children with Smith-Magenis syndrome and Angelman were seen to be very restless, because certainly that description sounded very characteristic of restless leg syndrome and its nighttime equivalent. So what is restless leg syndrome? You know, it's more common than we think in children. We know it affects at least 2% of school-aged children. The reason probably we don't pick it up very often in children is because it's quite hard for children to describe the symptoms. It's actually what we call a sensory motor disorder. It starts off with a feeling, and that's absolutely critical. You have to be able to get a child to describe a sensation in their legs, and that can be quite difficult for children, obviously, if they're non-verbal or if they're developmentally immature. So it starts off with a funny feeling in your legs, and it might differ. Some people describe it as tickly, itchy. I've had children talk about ants and crabs and spiders in their legs and this sort of thing, but it's an odd feeling. It's worse if you sit still or if you lie down. It gets better if you move, and it tends to be worse across the day, into the evening and at night. So independent of rest position or movement, just the time of day will also influence this. So as you can imagine, if it's worse when you're still and it's worse in the evening, when you go to bed and try to go to sleep, it's really going to kick off. And these are descriptions that children have given. And I think, you know, getting children, if they can, to draw a picture is very helpful and often gives you a lot of additional information. And we certainly do this in our clinic. And look at the descriptions the children gave. They're wiggling, wriggling. And the key thing is, I just have to get up and walk around. That real urge and that need to move. So getting children to articulate that is very, very helpful. So the consequence and the reason this is linked to sleep is that children can't fall asleep because their legs are annoying them and they have to keep kicking them around. And there is also a sleep cousin, if you like, of restless leg syndrome. Restless leg syndrome is very much a phenomena of wake. But during sleep, children also have these limb movements that can then wake them up. And it sounds suspiciously like that might have been what was happening with some of the children in Georgie's study. And we know that there is a very strong correlation with ADHD. And we think that's probably because both ADHD and restless leg syndrome share a common pathophysiology and abnormalities of the dopamine pathways in the brain. I haven't got a lot of time to talk about this, but the important message is this is very treatable. So a lot of these children have low iron stores in their bodies, and iron is part of the dopamine metabolism pathway, and that's why that's linked. And so what we do is we check out children's iron profiles and we treat them with a 3-month course of oral iron. And there's also nice recommendations that can be made around iron-rich foods. A little bit of exercise towards the end of the afternoon can also help. Okay, so I was going to just touch also on obstructive sleep apnea, basically because this is a very common abnormality in childhood, and it's certainly one that tends to be more prevalent in children with developmental disorders, but they're often due to sort of craniofacial differences. And as you can see, it's not a new thing, it's been around probably forever, but was first described way back in 1889 with some very non-PC medical terminology, and this was in the first edition of the British Medical Journal when calling a child stupid and lazy was deemed to be a perfectly reasonable thing to do. But it does highlight that very, very early on in the understanding of this condition, people recognised that it had impact on children's daytime sleepiness and alertness, and also on their ability to learn and perform in school. So what is it? It's a whole spectrum, actually. Sleep disordered breathing is a whole spectrum of events. And what I want to talk about is obstructive sleep apnea, which is the more pathological end of the spectrum. It affects probably between 1% and 4%, with some variation between age and body size and different ethnic groups. There's a peak age in children between the ages of 2 and 8 years, so that's sort of early school years. And there's also a second peak in adolescence because it is strongly associated with obesity. And that's some quite shocking data. I think every 1 point increase in your BMI, once you're above the 50th centile with your BMI, is a 12% increased risk of sleep apnea. And we know that it's caused in young children by crowding of this upper airway space, by the tonsils and by the adenoids. And the only way this part of your airway is kept patent during the day is by muscular contraction. And as the body relaxes into sleep and those muscles relax, that causes narrowing of the airway. And normally we tolerate that natural narrowing, but if you've got big tonsils and adenoids, or if you've got a lot of fatty tissue in your neck compressing the airway, it can cause a critical closure of the airway leading to apnea, which is where the child is trying to breathe against a blocked airway. And we know that has lots of adverse consequences. There's probably been more research into this sleep disorder than any other sleep disorder, including studies numbering 1,000+ children. And we know there are very widespread adverse effects on behaviour, physical well-being, but importantly on neurocognitive outcomes. So for a child who's got a limited cognitive reserve, who's already got a learning challenge in their life, what the last thing they need is an additional challenge in terms of obstructive sleep apnea. So it is terribly important to be vigilant for sleep apnea in children with developmental disorders. And what you need to know, and what is very well understood, is that parents struggle to spot this, but also so do clinicians. And the reason being that a child might be gasping and snorting and snoring and stopping pausing in their breathing overnight. But when they're seen by a doctor in the surgery or in their clinic, they look absolutely fine. And that's because when they're awake, their airway is patent and it's only noticeable during sleep. So the critical thing here is that if a child is thought to have sleep apnea, if they're snoring and gasping at night, and there are concerns about their breathing from the parent, they have to have a sleep study. You can't make this diagnosis just by hearing a story. Home videos, incidentally, are also very helpful to clinicians. So just to summarise, children with tuberous sclerosis complex are vulnerable to chronic insomnia, as are all children with developmental disorders, and we know that that should be always a primary focus of inquiry. And I would sort of add in here that I think prevention is always better than cure, and I think early promotion of good sleep habits is terribly important. And I think it does often get lost because often families in the early years are very preoccupied, understandably, with the new diagnosis, often investigations into new manifestations of that diagnosis, and sleep tends to get put to the bottom of the pile, which is a great shame because we know how pervasive the adverse side effects of poor sleep are. And I think early prevention with good sleep habits can go a long way to avoid a lot of that future difficulty. Sleep disorders like sleep apnea, restless legs and parasomnias, they're common in all children, but they can be overlooked in children with developmental disorders because of diagnostic overshadowing. The focus is all on the tuberous sclerosis and not on sleep. And parasomnias are an important differential diagnosis in both directions with epilepsy. And I think, my major sort of plea would be that for families listening, that they actively seek help for children's sleep disorders or worries about children's sleep and recognise how important that is both for them and for their child. NHS provision is patchy, it's growing and it's developing, but I think it's important that this critical area of the child's wellbeing is addressed. So thank you for listening. Apologies for the technical hiccup there. I hope I'm still online and very happy to answer any questions.
Thank you both so much for your really interesting talks. I wondered if Georgie just wanted to show her video, sorry. We've had a question come through asking about the context that the flat pain scale has been designed to be used in. And Georgie, I didn't know whether you wanted to comment on that.
Sure, sorry, I didn't explain that very well at all. So it's an observational measure. So it's designed to be used by anyone, so a parent or a clinician or a teacher. And the idea behind it is just that you observe your child or the child you're caring for about 10 minutes and rate each of those 5 kind of scales. And I think I should have said as well that what can be really helpful, as Kathy was saying, is if you record the child that you're working with for that time, and then you can code them, but you can also show that to your clinician. And that, because again, often children will say, or families will say to me, but they don't look in pain when we go to the GP. So it's kind of having that evidence when you go in, I think can be really helpful. I hope that answers your question.
Yeah, and I was just wondering in terms of Kathy mentioning about recordings of sleep, and so using video technology, but I was just wondering whether there were any other sort of sleep aids or even sort of a protocol in which you should be recording at night, or if there's any recommendations of actually how to do it in practice.
Wow, it's a really interesting question. There should be, shouldn't there? I think it's such a new field. We're all frantically learning. And one of the major challenges we have is actually, what do we do with that video material? Because I would say probably most families I see in clinic now will bring video material, usually on a smartphone, because we've all got that instant, often incredibly high quality technical access, haven't we? And it's very difficult to know what to do with it because it's quite hard to integrate it into medical records. It's very personal material, so it creates all kinds of problems. So different hospitals around the country are trying to wrestle with that. I learned from my parents, to be honest. So we have a lot of families who are now kind of buying access to cloud storage for various, they're often kind of commercial CCTV cameras, aren't they? So they're actually quite well suited to purpose. So they're infrared, they work in the dark, they're often movement triggered. So rather than having, a whole 12 hours of recording you've got to go through in the morning, you just get the sort of movement. And I think quite a few people now actually alert parent on a phone that the child is moving so that they can sort of tune in and see actually what's happening. So I think there's some fantastic technology out there. The NHS is very slow to catch up. So the videos that we use are ones that integrate with our PSG technology, and they're kind of chunky cameras, and they cost, you know, £2,500. And I know I can buy something from, you know, Hong Kong that costs 50 quid that does exactly the same job. So yeah, watch this space really. But I think that the sleep clinical world is sort of catching up a little bit around the whole discipline of how you look at video, how you score video. And I think the work you've been doing looking at video, looking at pain, is incredibly interesting and helpful. And we're starting to do similar with home video with children that have movement disorders at night. And I think we're probably the only service at the moment that's doing home video as a routine clinical service, so, you know, sending videos out and then getting a technician to score them. But it's such a fantastic technology. And I think, you know, if there are parents and clinicians certainly on the call, I think one thing we have to be really cautious about, certainly in research, but also advising parents, is that you know, people can hack into these systems, so people have to be mindful of what information they're happy to be, you know, seen by other people.
We have one more question in the chat. I didn't know whether you wanted to answer now about how to actually get a sleep assessment and take part in a sleep study.
Kathy, I feel like, yeah, that's
yeah. Research study or a clinical study, I wasn't quite sure.
So can you get a sleep study done privately?
Oh, privately, golly. Yes, there are plenty of private sleep centres out there. I mean, you should, you know, everybody in this country should be able to access a regional service that would do respiratory sleep studies. Not all regions are what I call the more neuro side. So the ability to do things like, you know, look at limb movement disorder at night, for example. But for sleep apnea, you know, every child should have access to a regional sleep service. But that would normally be via the paediatrician. Sometimes people struggle to get to their paediatrician, and I think it's then a challenge, isn't it, about parents being assertive with GPs and bringing videos in and possibly bringing information about sleep apnea.
or using some of the resources like the sleep diaries and recording the information by the sleep diaries, which are really helpful. We have had another question come through, but I am going to suggest that we keep that for the live Q&A. So thank you so much to Dr. Georgie Agar and Dr. Kathy Hill, who will be sticking around for the live Q&A at the end. So if you do have any questions, then please attend that session at the end, where we'll be having a more open roundtable discussion. So we are going to shift slightly in terms of our schedule, just because the first two sessions are going to carry on for a little bit longer than the final session with Petrus de Vries. So if I suggest that we come back at 10:50 to start session 2, and you don't need to leave the link, so we'll just have a hold-in screen on the screen, and then you'll know when the session started again. So we'll have a quick 12-minute break until 10:50.